Thank you for joining us. My name is Dr. Brent Martin. I am the DentaQuest Dental Director for the state of Tennessee. We are located here in Middle Tennessee in Nashville, and today I'm going to share with you one of the more exciting developments in clinical dentistry that has come along, certainly in my career. Our agenda today is introducing myself and what our objectives are, some of the healthcare milestones that have happened in both medicine and dentistry, and we want you to be aware of the literature citations that has brought us to this very, very important, what I call sea change event in dentistry. If we see this patient that presents here on the slide, we've all seen this, gross caries, and sometimes the patients are in pain and sometimes they're not. Another case after the SDF, that's the acronym for silver diamine fluoride. We know this is the ADA code D1354. Medical management with SDF, a clinical breakthrough therapy. It is low cost. It also minimizes operating cases, and it is extremely important for those patients to present with a high level of anxiety or fear. Most of us in our clinical practices have seen children who come into the operatory and they're not about to have you do any invasive therapy or treatment. They probably are very resistant to even having anesthesia and the shot infant. This particular material allows you to treat that child, do something to arrest that caries, even if you, God forbid, never saw them again. This is not invasive, and we have a lot of examples of providers who say, well, let me just paint this on with a little micro brush, and the child tolerates it, and you know you did a wonderful service for the child. Our goal is to introduce SDF, silver diamine fluoride, as a fundamental and permanent change in our thinking and our dental practice patterns. This change is based upon the latest research and breakthrough therapies. I want to share a few medical milestones to begin with and establish how we are looking at this. In medical milestones, digitalis is a drug that physicians would tell you they could not have ever done without. Another one is aspirin, one of the most important medications ever available to the medical profession. Antibiotics, certainly we all know of Alexander Fleming, 1937 with penicillin. We know the statins are very, very important to now. Most research says about 35% of all the United States population are on statins. Now let's talk about dental milestones. Anesthesia, there had been no anesthesia before Dr. Wells in 1846. The fluoride impact with Dr. McKay and G.V. Black when they began looking at these people that had no decay, although they have a lot of fluorosis. The so-called handpiece air rotor, now becoming an electric air rotor, from Borden. Bonding. Prior to Dr. Bunakori, it had never occurred to someone that you could actually adhere something to dentin or enamel. So Bunakori was the first person that began looking at the ability to bond something to a tooth. And without lidocaine, we would have a hard time doing our jobs because we couldn't attain anesthesia. The latest milestone that I'm sharing with you today is silver diamine fluoride, ADA code 1354. Here are a few indications of silver diamine fluoride. I usually tell people in presentations that the material is an absolute adjunct, a wonderful add to our armamentarium. It will turn ugly, decayed, brown teeth that the child presents with into ugly, decayed, black teeth for a short period of time. At TennCare, the program will allow us to restore after the caries has been stopped and hibernated. So you're looking at about a 30-day window of time, and we know that there's about a 90% acceptance by responsible parties for posterior teeth and about a 55% acceptance for anterior teeth, but it will stop the caries process. I'm doing a literature search. I found a New York Times article in August, late August, talked about children being sedated for dental work. I think we can agree that all of us have it as an objective to lessen, to minimize the number of children that must have general anesthesia. Sadly, we remain aware of the numbers of deaths that have occurred in the United States. And of course, one of the most painful recently was in Texas, where a child was put to sleep and at autopsy found that there was no evidence of dental decay. While that's rare, we do know that there are many cases that are actually done in operating rooms that we could or should do in our operatories. Silver diamine fluoride will make it easier to avoid some of the risk to the children from general anesthesia. Untreated dental caries is widely acknowledged as a significant pediatric public health problem. I give you a quote here from an NCHS data brief that kids age 2 to 8, 1 in every 7. There's other literature citations that use higher numbers. The last bullet point on this slide talks about SDF has been used internationally for decades, certainly in Japan. And as reported in a recent published meta-analysis, 2/3 of all dental caries studied that had gotten into the dental were found to be arrested after treating with SDF. So what can we do as clinicians to lessen the number of children that are exposed to general anesthesia? We must immediately implement the use of silver diamine fluoride to every patient, where it is clinically appropriate. If there's 1 lesion, if there's 2, or if there's 9, we really believe strongly that silver diamine fluoride will help the child become asymptomatic and lessen the risk of having to go to the hospital for pulpotomies and root canals and so on. Peer-reviewed literature is important to all of us, and here I'm quoting an article that says that SDF may be better than fluoride varnish and is certainly better than no treatment in arresting and preventing cavitated carious lesions. UCSF, University of California, San Francisco, is a real leader in this, and Dr. Jeremy Horst is on the staff there. So they use the phrase in quotes here: for any patient with active caries, we recommend considering replacement of fluoride varnish as a primary means to prevent new lesions, and the application of silver diamine fluoride to the active lesions only. And I give you a link there to a literature citation, which is an excellent article. In 9 randomized clinical trials in which SDF, silver diamine fluoride, was applied to multiple teeth, the only side effect was 3 out of approximately 1,500 patients, both children and elderly, monitored for 1 to 3 years. And those 3 experienced a small, mildly painful white lesion about the size of the head of a pin on the mucosa, which disappeared within 48 hours. So we know that it is extremely safe. In Tennessee, we're very pleased that the Dental Practice Act allows both hygienists and dental assistants under the General Supervision Clause to place SDF because it is a fluoride material. Application twice a year outperforms all, repeat, all minimally invasive options, including the ATRs or atraumatic restoration technique, but it's 20 times less expensive. It approaches the success of dental fillings after 2 or more years and prevents future caries while fillings do not. Silver diamine is widely accepted as more effective as a primary preventive than any other material, with the possible exception of dental sealants, which are 10 times more expensive. And we all know that the efficacy of sealants declines over time. The efficacy of sealants is at its best within 2 years, but when you look at pit and fissure sealants at 5 years out, they are not as effective as they were initially. SDF stops the decay. Here I give one of the periodicals that we all get, Decisions in Dentistry, if you want to look that up and read what they said about the material. SDF is the future. So here are a few clinical tips that would help as you move this into application in your practice. Dryness prior to application enhances effectiveness, which is true for most things that we do. Good patient management is still profoundly relevant to the very young and otherwise challenged patients. Through this 1-minute intervention is more tolerable than other options. We are aware, as I alluded to earlier, where an apprehensive child would not tolerate or allow invasive treatment, but these children do allow application of SDF. Silver diamine fluoride can also replace fluoride varnish for the prevention of caries in patients who have active caries. I would also share with you that this is not just or only about children. While in Tennessee we do not have coverage for Medicaid for patients over the age of 21, the material is widely used and accepted for class 5 lesions, especially on posterior tooth. In elderly patients, it will stop the decay process. The protocol that is used, as advised by Dr. Horst, apply to carious lesions or high-risk surfaces, dry the surface when you can, application of Vaseline to the gingiva in case you drip some there, 1 minute, rinse gently, and then we give you a body weight maximum limitation, which it would be very, very hard to approach that with the kids. Here's another quote from Dr. Horst that I used earlier in the webinar, a 95% approval or selection of this option for posterior teeth and about 50% for anterior teeth, because we will want to get a consent form signed by the responsible party before we use SDF. We also separate treatment days for SDF and any restorative material. That would be because we want the silver diamine fluoride reaction to go to completion. It would be illogical to apply the treatment, the material, on a Monday and expect to restore the tooth on a Tuesday or a Wednesday or a week later, because the material has to have the reaction completed. So one of the things we do find is effective is to apply SDF during the initial diagnostic visit, ART or aid traumatic restorative treatment over it on treatment visits. It also can be used as an indirect pulp cap cavity liner, understanding that discoloration may occur to some composite filling materials. However, it will not stain non-carious tooth structure. So if you get SDF on an adjacent tooth that has no caries, it will not stain. You see at the bottom bullet point here that 80 to 90% success with multiple applications is what it says. I give you a literature abstract here, and in the middle of it I highlight in red the most important part. The overall percentage of active caries that became arrested was 81% with a 95% confidence interval. That is huge. What is it? Silver diamine fluoride composition is 25% silver by weight, 8% ammonia, and 5% fluoride. I asked Dr. Horst, how long do you find that it takes to thoroughly arrest the caries? He said, told me about a year ago. We do not have an exact answer, but the initial response, it occurs usually in 1 to 2 weeks. Repeat application is essential, so that's why we, in processing silver diamine fluoride claims, will allow 2 per tooth within a 1 month period of time. Oop, we got a slide up here we don't want. Benefit guidelines. In Tennessee, this will not be history violated against other fluoride treatments, although you cannot do Code 1206 fluoride varnish on the same day. Out of an abundance for caution, we never want anybody to say that the child might have gotten too much fluoride. So 1206 or other fluoride treatments will be a covered benefit, but not on the same day as D1354, silver diamine fluoride. It is not history violated today against sealants. However, to be compliant with the ADA coding and nomenclature change, we do believe that will be updated on January 1st of next year. And that certainly makes sense to a clinician that after you had used silver diamine fluoride on the occlusal surface or the buccal surface or whatever, tooth number three, there would be no reason to apply a sealant. So there will be a history cross-check update of sealants after January 1st per tooth. Allow 2 applications in Tennessee within 1 month, and a lifetime limitation of, that's going to change too, of 4 applications per lifetime now. We do ask that you defer restorative treatment based upon the literature. and reaction has approached completion, which means a minimum of 4 weeks interval between the first application and restorative treatment. And we will allow as a per treatment visit like fluoride varnish today, but the ADA coding committee changed this to per tooth, so we will be changing in 2018 to a per tooth benefit. It is very important here that we know that you also can do whatever you want after the SDF was applied and the reaction went to completion. You could do a composite, you could do an amalgam, you could do the procedure that you think is most appropriate clinically after the material has reached its completion. And I'm told that the dentin will be just as hard as concrete when you come back in. Some docs even tell me that they don't even need a handpiece as long as there's enough room to veneer over the SDF material and the carious dentin, that they don't even need to do a handpiece, which the children enjoy. Okay, we don't have questions obviously on this webinar. At the time that we present, we'll be able to entertain some questions. But thank you for joining us. I am very, very committed, and I hope you will be too after this brief webinar, about the values that this material will bring to your practice for the good of the kids that we all treat. Thank you.